ايوه الان بدات تسجل في الميتنج لان احنا بدينا. رحب بكم جميعا واشكركم على الحضور، واتمنى ان يتوسع دائره الحضور حتى يتم الاستفاده منكم، وايضا تبادل هذه الافكار سيعيننا في بناء الصحه في ليبيا. في الحقيقه الاريز، المناطق اللي فيها عجز واضح في ليبيا تكاد تكون محصوره. يعني مثلا نبدو من الهانديكاب، يعني الأطفال اللي هم ذوي الاحتياجات الخاصة. يعني المجموعة تكاد تكون يعني ما هيش حاجة صعبة، وهذه تلقى في مساعدات دولية كثيرة. أنا أذكر مثلا من التجارب الجميلة في ليبيا اللي بدأناها في منتصف التسعينات، اللي هي جمعية داون، متلازمة داون. يعني في سنة 2004 تقريبا أو 6 صار لقاء هيك لمتلازمة داون، وفوجئنا بأن السويد بعث ناس تشوف التجربة الليبية، يعني من شدة إعجابها بالتجربة الليبية، ليس فقط لكونها تحمل الكثير من المساعدات لهؤلاء الأطفال، ولكن في دولة يصعب فيها القيام بأي عمل، فما بالك لذوي الاحتياجات الخاصة. وأذكر أن احنا قدرنا نديروا منهجية في هذا الموضوع، وكنا محتاجين حقيقي لأشياء بسيطة، يعني كمبيوتر، جهاز كمبيوتر صعب الحصول عليه. الدولة الليبية من زمان للآن على فكرة ما فيش حاجة تغيرت، هي دولة اضطهاد لا أكثر ولا أقل. يعني مثلا يقولوا لك اوكي كويس دير جمعيه ونشط وكذا، وبعدين يسكروها لك من كل جهه. ممنوع التواصل مع الجمعيات الدوليه، ممنوع التواصل مع المنظمات الدوليه. والان تكرر هذا للاسف. يعني هو صار في 96 97 انا كنت مدير اداره التعاون الدولي في الصحه، ووجدت صعوبه جدا جدا واكثر. انا ارى دكتور ويليام، مرحبتين. Welcome, William, Dr. William Novac. My name is Idris. Hi.
Fine. Thank you. Sorry I'm late.
Yeah, it's okay.
And another emergency issue come up, but I'm glad to be able to join.
Yes, thank you very much. We welcome you so much.
Hi, William. Thank you very much indeed. I think we'll hopefully we'll be starting very soon. Maybe we'll let Idris finish his statement, then we'll proceed. Okay. Go ahead, Idris.
Yeah. Okay, so it is. Let me speak English, Rida, if you don't mind. So
sure.
William can. So it is a matter of who is doing what. The international cooperation is something normal. It is everywhere. It is everywhere. I remember when I worked in UK, I went to Hungary just to see how they do with the handicapped kids. They have very good physiotherapy. Even Britain learned from other countries, let alone our country. Really, we should use these opportunities. We should invite as many as possible from all these organizations, especially in the areas where we need their help. I was calling, Rida was with me, calling the government to seek advice in coronavirus pandemic, because we have very little experience. So here we are. Now we come to cardiac surgery. As I was told by my friend Rida, that there are maybe 2,000 kids, they need operation. And they need this operation as soon as possible. And every year there is more children with congenital heart diseases every year. And because of what is happening in Libya, the most difficult task usually get neglected. And cardiac surgery, it's very complicated, sophisticated uncertainty around it. So it is something which needs a lot of good administration and good preparation. That's we lack. We lack all this. I'm not going to take longer, but I just made contact last week with one of the organization in Canada called HOPE. I explained to them in 2 occasions the situation of cardiac surgery, and they're willing to listen to us and contribute to the organization we are supporting, if we can provide provide them with good proposal. I hope we'll do that, me and Rida, with the help of William soon, and then we can get restart this cardiac surgery among kids in Libya. So I welcome Dr. Novac, William. The floor is yours, William.
If you allow me just to give a brief introduction to William.
Oh, yes. I was about to say that, Rida. Welcome.
That's all right. Okay. Professor William Novac is famous in many countries, not just in Libya. But I think you need to just walk with him in a hotel in Benghazi, and you see that people, I think nearly everyone in town knows who William Novac is. So I need not to make a long introduction, but really he is one of the pioneers of pediatric cardiac surgery, particularly charity pediatric cardiac surgery in the developing world. And in 2011, I was head of international cooperation at the new Ministry of Health, and Professor William emailed me to say that we know there's a lot of, one Libyan doctor, I think his name was Khadija, in America, contacted him to tell him that a lot of kids in Libya have no access to pediatric cardiac surgery, and a lot of them are dying. And we started communicating. It took us nearly 8 months to be able to bring him back, to bring him for the first time to Benghazi Medical Center, where he started a pediatric cardiac surgery program on visits basis during that year. And after that, he had a contract where we managed to get a full-time program, I think, for a year in Benghazi Medical Center, which didn't last for long because of the war, and he had to leave. Then when I came back to as a Minister of Health in September 2014, I contacted him. I said to him, you need to come back, kids are dying. And I invited him to go to Tobruk because Benghazi was not considered to be safe at that time. He stayed in Tobruk for nearly a year or more than a year, and then he started coming back by end of 2017, I think, to Benghazi. Since then, the number of visits have been extremely limited. Since I left the ministry, the funding was becoming scarce, and I think I know because the government didn't have enough hard currency to be able to bring him in. And he one day asked me, he said to me, Sarraj asked me to come and go and see him in Tripoli. I said, yes, please go ahead. And he went, and I think we also managed to get an agreement to start or support the pediatric cardiac surgery program in Tajura. But that also collapsed because of the war again in 2019. And we went back to square one now in Benghazi Medical Center. This year, William did only 2 visits to Benghazi, to whole Libya, really. And in every visit, he will do somewhere around 30 cases. I'm not exactly sure about the number, so forgive me if I get the number wrong, William. But now, really, the problem is that we have no funding. We have no plans for William to come back. And we have, as you highlighted, Idris, nearly 2,000 kids awaiting open heart surgery in the East, South, and West. And today we will hear from Professor William about his experience, and we'll learn from him what will be the best way forward, because we are really struggling to get the necessary funding to do that, to pay for the tickets, to pay for the essential supplies and staff that has for him to bring with him all the way here. And really, his ability to operate really can only be matched with his ability to coordinate, which is a very impressive coordinator, and the team works like wonder, really. Their ability to be able to bring people to volunteer to work in Libya is very impressive. William, the floor is yours.
Thank you, Rita. Now that you've given my talk, can I just take some questions? So I'm going to highlight a number of the things that Minister Oakley mentioned, and I'm going to add some thoughts to the issues as I see them or have seen them since 2012. So let me share my screen with you here if I can. Do you see that?
Yep.
Yes.
You could go.
Yes.
Yeah.
Yeah. Let me put it in the right format here and get it in the right place. Well, excuse me. I thought I had it set up correctly to start with. There we go. And I'm going to remove you guys from my taskbar so I can actually see things. So, Libya's problem for children with heart disease. As Minister Oakley pointed out, there was an American Libyan pediatric cardiologist who visited Libya not soon after the fall of the Gaddafi regime. She was from the University of Chicago, and Huda El Sheri, when she got back, she called me and sort of described the situation for children throughout the country, but mostly, quite frankly, her concerns were the East, because there was absolutely no pediatric heart surgery in Libya outside of Tripoli at the time. And so in this new state, if you will allow me that, nobody was quite sure who was covering the cost of what. Tripoli did operate on children both in the, at that time, mostly in the public sector. Dr. Hassan Magur was the only one operating, and Hassan was doing somewhere in the neighborhood of around 300 to 350 cases annually total, pumps and non-pump cases. I see that Taha Guela is with us, so Taha, if I make a mistake, please don't hesitate to correct me on that. As a consequence, I was put in touch with Reda, and we organized the very first trip into Benghazi Medical Center at that time. The first trip was actually only 2 weeks in duration, and you know, it was quite interesting to all of us. So I'd like to play a video now for you that we made during our time in Benghazi.
Libya has a long history.
We're not seeing that video.
Oh, you're not seeing the video?
Yeah.
Oh, okay.
I have to
Well,
share the,
Program there.
I have a different way of doing it.
And in 2014, the Civil War broke out.
So are you seeing this
We
video?
were literally there. Hospital was in the crossfire. And we were in the West when the Army of the East decided they were going to try and take Tripoli.
Between battles between a warlord and government-backed soldiers have happened hundreds dead.
William. So we're not seeing the video. Can you share?
Okay, well,
I think stop sharing and then share that same
yeah,
link that's open.
Uncomfortable. But I think
yeah, I'm not quite sure why you're not seeing the video, quite frankly. So let me tell you that I will forward to Reda the video, and he can send it out to all the participants later, but it is a video that we made about our efforts in Libya. This video was made in 2019, pre-COVID. You see my screen now, no?
Yeah.
Okay. So Reda will send the video out at the close of the session, or at least I hope he will. So let me give you a little bit about our efforts over the years in Libya, cases by year, city, and then a cumulative sum on each successive year. In year one, we made actually 2 trips. That was in 2012. And at that time, we made 3 trips, and we operated on 68 children in 2012. In 13, not a dissimilar number. And as you can see, the blue is Benghazi Medical Center, and the orange or yellow, whatever you prefer to call it, is the cumulative effort. Again, back to Benghazi Medical Center exclusively in 2013, and then again, excuse me, in 2014. Now, although the numbers did increase slightly from 68 to 82, I mean, realistically, with 500 children born annually with heart disease that's going to need some form of intervention, whether it's in the operating room or in the cath lab annually in Libya, you can see that operating on less than 100 children a year makes some difference, but it really doesn't care for the problem. As Rita mentioned, in 2014, we were actually in Benghazi Medical Center at the time that conflict broke out in the city of Benghazi in a major way. And actually, the Benghazi Medical Center was sort of no man's land with the two sides on either side of the hospital. So in the evenings for entertainment, get ready for this, we would go out on the balcony of the top floor where we were housed, and we'd watch the tracer fire and rocket fire go over the hospital from one side to the other. We had quite a collection of shells eventually out on the balcony that just fell out of the sky. But as you can imagine, that was our last trip to Benghazi, and that was in May of 2014. We literally had to have the two sides hold a 30-minute truce period so that we could take the road that they were, one of the roads they were fighting over outside the city on our way to Al-Baida. That was uneventful, except for a very interesting series of car rides. Rada petitioned me in September of that year to return to the East. And he basically gave me two options, either Al-Baida or Tobruk. And so in September of 2014, I flew in, and Rada and I visited hospitals both in Baida and Tobruk. And what we found upon entering Tobruk at, very interestingly, at 11:30 at night, that's when the helicopter got us to Tobruk. We opened one of the cardiology storerooms, and lo and behold, there's a cardiopulmonary bypass machine and heater cooler, which had never been unpacked. So they were, yes, a little bit old in terms of the model, but they'd never been run. And so that made the decision pretty easy for us. If there was a bypass machine there, then all we had to do is provide a backup bypass machine and heater cooler to get things started. We collected a considerable amount of equipment because Tobruk Medical Center really did not have an adequate amount of equipment to care for children with heart disease after surgery. So we brought in ventilators, monitors, syringe pumps, a bypass machine, a heater cooler. It was quite an assortment of equipment that was brought to Tobruk Medical Center in 2015 when we returned there in February. We operated solely there. Those 96 patients represent 3 separate trips of 32 children per trip. And then in 2016, we continued mainly in Tobruk, operating on another 151 children there, but we made one trip into Benghazi Medical Center and operated on 39. And then funding really literally fell from the floor. There was no more funding at the end of 2016. And the trip that you see listed there in 2014 is actually a trip that Rada managed to find some donors, private donors, and we fulfilled that trip to Benghazi Medical Center. Then in late 2017, I was contacted by one of the medical committee of the Presidential Council to consider coming to Tripoli. I spoke to Rada about this because I wanted to make sure that this was not going to be a political move that was going to disrupt our coming back to the East ever, and he did not think so. We made our first trip into Tripoli in June of 2018. As you can see, we continued into Brook at that time. During 2018, we actually operated on 137 children, and we were able to provide interventional cardiology procedures to another 15, I believe. At the end of 2018, you can see that we've gone from doing merely 68 kids as a cumulative number in 12 to almost 800 children at the end of 2018. And although we felt this was an accomplishment, if you look at the yearly flows, there's only a couple of those years where the numbers even approach 200 per year. That's number one. And number two, as you can see from this graph, there's really not enough volume or actually consistency in trips for us to be able to actually train a pediatric cardiac surgical team. In 2019, we were able to get some additional funding to come back to Benghazi through the Ministry of Health. We made one more trip to Tobruk, but unfortunately 2019 was a disruptive year in the West. Politically, the budget didn't get passed in the West until very late in the year, and we were only able to actually facilitate one of what should have been 5 trips during 2019, and that occurred later in the year on top of that. 2020, again, we had some very serious issues with COVID. And that year we made one trip into Benghazi and one trip into Tripoli. And actually the Tripoli team had to leave a week early because we were informed that the borders to Tunisia were going to be closed. And in actuality, the surgical team got out on the last day that commercial flights were flying. And the Deputy Minister of Health in the West helped secure the medical evacuation jet so that when the ICU team was ready to leave 5 days later, they were able to leave and go through Tunis and then go to their particular countries of origin. This year, we made 2 trips. This is a very unique situation. One of the trips was actually the first trip that we made in February was funded by the Ministry of Health. It had been funded the previous year. And so this was actually holdover money that we were sitting on, waiting for us to be able to get back after COVID. We made that trip in February. And about 3 weeks into the trip, Dr. Naima Guba came to me and asked if we could stay an extra 2 weeks because she knew that we were supposed to go to Tripoli immediately after the Benghazi trip, but she also knew that that trip had not received approval yet from the Presidential Council to be made. And so as a consequence of that, the team decided to stay for an additional 2 weeks. So that trip was actually 6 weeks in duration, and we operated on 70 children during that trip. And then this last trip that we completed in June, actually we operated on another 47 children. It was only a 1 month long trip. That trip was funded entirely by a private corporation in Libya, a private medical corporation that had also helped in February to extend the trip by 2 weeks because, quite frankly, the Ministry of Health was unable to cover it. Now, let me say that I don't think the timing of our February trip could have been more interesting, as Libya was going through the process of reunifying the government and choosing a prime minister and a new presidential council. We were there when that happened, and we were there when the parliament agreed to the initial cabinet that the prime minister presented. It may not have been the actual initial cabinet he presented, but they did agree finally on approving a cabinet for him. So he had the good fortune of meeting the new Minister of Health, Ali Zanati, I think 2 or maybe 3 days after he had been appointed. we had already put together a program plan for a 1 year, what we call the 1 year program, where the surgical team is on site between 36 and 38 weeks a year, and the ICU team is on site between 44 and 46 weeks out of the year. We were able to go to that meeting with Dr. L. Oakley and Dr. Guba, present this proposal to the minister, who at the time said that he was in favor and would approve the proposal when and if the budget ever got passed. And as all of you know, the Parliament has taken a break for Eid, and they did so without passing a budget. And so we're not sure when our next trip to Libya will be, as a consequence of the lack of what I would call normal governmental funding for a program for children with heart disease in Libya. Now, I know this link is going to work because you just saw it. So in my frustration, can you see this, folks? You see this Libya Herald page? Hello?
No, we can see only the link again.
I'm sorry. Well, I'm not sure. I had it all embedded and apparently doesn't want to show up.
William, if you share your screen instead of the PowerPoint presentation, you might be able to show us that link if possible.
Show you the link?
Everyone here. So right now, I think you're sharing the PowerPoint slides.
Yeah, and do you see the link pop up?
No, because I think that's happening outside the presentation.
No, it's not showing up again.
If you minimize your presentation, maybe, or stop sharing the PowerPoint presentation.
Now, how about now? Can you see it now? No.
No.
Okay.
We still can see. We still can see the PowerPoint presentation in a minimized version.
Okay. Well, I've been unsuccessful in my technology then, which is really no surprise considering that this is not something I routinely do. At any rate, let me just say that a week ago, I wrote an editorial to the Libya Herald expressing my frustration with the fact that children were dying daily as a result of their congenital and/or acquired heart diseases, and that they were going to continue to die because there was no funding for providing pediatric cardiac surgery for our team to come, and we had no idea of when this was going to occur. This was published in Libya Herald a few days ago, and I will have Rita send you all the link to that when we're finally done. So let's just review this a little bit so that everybody knows. I've got this set up as the total number of cases by city, the start and the end date, and the total trip number that was performed to that particular site. So in Benghazi, we started in 2012, and as you just heard, I would say we're still there with 2 trips that we made this year. I just have no idea when we're going to be going back. The total of 18 trips. Now, let me say that most of our trips to Benghazi after 2000 and mid-2013 were no longer 2 weeks long. They became 1 month trips. I think we had one 5-week trip, and now, as you just heard, we had at least one 6-week trip. So we didn't operate on 518 children in 18 2-week trips. Just let me make that clear. In Tobruk, we started in 2015. The last trip that we made there was in 2019, a total of 11 trips. They were all, with the exception of one, they were all 1 month long trips. And we operated on 370 children. We averaged about 34 children per trip if it was 1 month in duration in Tobruk. In Tripoli, We started our first trip in June of 2018. And we made our last trip in late February, early March of 2020. A total of 7 trips. 6 of those trips were 1 month in length, and 1 of those trips was 2 weeks in length, and we operated on 219 children. So altogether, between 2012, when we initially came to Libya, and this last trip that we just completed at the end of June in 2021, we've made 36 trips to Libya, and we've operated on 1,106 children and provided interventional cardiology services for approximately another 15. Now, this is interesting. Funding sources over the years for these different trips. I'm going to show you the funding sources by city. So in Benghazi, Benghazi Medical Center actually funded the vast majority of trips, although the Ministry of the Health of the Eastern government did pick up trips after 2016. And then we did have a medical company in Libya provide for 1.5 trips, if you will. In Tobruk, the Ministry of Health of the Eastern government funded most of the trips. The WHO funded 1 trip, and private donors funded 1 trip. Dr. El Oakley actually secured these private donors to fund the trip to the degree at which we could actually carry it out. And then in Tripoli, the Presidential Council of the internationally appointed government of Tripoli has funded all 7 trips over there. There's no private funding. There's no funding from the Ministry of Health of the West. This is all funded directly out of discretionary funds from the Presidential Council housed in Tripoli. Why haven't we trained a local team yet? And that's a question that I have received, I would say, more frequently lately. And typically it comes from individuals that don't actually have knowledge or understanding of how long it takes to train someone to become a cardiac surgeon, a primary cardiac surgeon, and then on top of that, a pediatric cardiac surgeon, and then add to that becoming facile in neonatal cardiac surgery. You know, this is something which has to have a continuous presence. This education cannot be broken up routinely like it has been over the years at all the sites, whether it's been in the East or in the West, quite frankly. We have never had a program that ran longer than 6 months on either side of the country. Yes, we've had obviously been in different cities for more than that period of time, but if you look at the timelines on our presence there, they're disrupted quite frequently, and the longest period that we've been on either side of the country was a 6-month period in Benghazi and a 6-month period in Tripoli. Those were programs where the team would fly in for a month, ICU team would stay over, the surgical team would leave, and 1 week or 2 weeks later, the surgical team would return, a new ICU team would arrive, and we would run through this cycle routinely. We did this both in Benghazi from late 2013 until late May of 2014. And we did this in Tripoli from June of 2018 through, I think, December 21st of 2018. So, you know, really, we have not had the amount of time, uninterrupted amount of time, to provide the necessary education, in our opinion, in order to have truly independently functioning pediatric cardiac surgical teams on either side. Now, there have been a number of disruptions, which I think Rita has described to you fairly well. But I think there is something that's really important that I don't have on this slide that I need to mention to all of you. And that is that regardless of whether it's Benghazi or Tripoli that receives a continuous educational and clinical program, or whether it's both, human resources, local human resources, local healthcare professionals have to be both adequate in number, adequately motivated, and adequately supported by whichever hospital administration they happen to be working through. I can tell you that with the exception of this initial program at Benghazi Medical Center for 6 months and the initial 6 months at Tajura, that has never happened in all of the years that we've been there. People have rotated in and out. Yeah, the pediatric cardiologists are the same, but we've had surgeons rotate in and out, surgeons that have taken off and gone to Egypt for study, surgeons that have taken off and gone to South Africa for study, which I think was a good thing, actually. Taha, so don't get upset with me. But there have been inconsistent human resources and absent human resources, in particular, in both Benghazi and in Tajura. And that particular resource that has been absent has been anesthesiology. We really have not worked with anesthesiologists at either site in a consistent fashion. And so we've not really been able to train anybody in pediatric cardiac anesthesia as a result of that. Conflicts, obviously, on both sides of the country have disrupted the program in a major way. The civil war in 2014 and General Haftar's attempt to consolidate all of Libya in 2019 and 2020. There's also been political disruption on both sides and inconsistent funding, which I would say, if I had to pick one thing that has really been the most problematic, because, you know, folks, I mean, we've been on both sides of the country during these conflicts. And it's not a matter of whether we will come in when there's conflict. We've obviously proven that we'll do that, but the real issue has been inconsistent funding by a government on either side, or the new unified government, which has made a promise to fund a program, but has yet to pass a budget in the parliament. And that's sort of the last thing that I have there. The last one is still ongoing now because Parliament has gone into recess for Eid and will not be coming back until after Eid is over. So, you know, this has made it very difficult for us. We can't make any plans. Locals can't make any plans, and it's completely. This new government has made a lot of promises, but they've been unable to fulfill them, secondary to the infighting that's going on in Parliament over passing the budget. So let me say what I think Libya needs to do in order to provide for their children with heart disease or defects. The first thing that really needs to be brought to mind is that Libya needs to realize the magnitude of the problem that they have. They have a waiting list now of between 2,000 and 2,500 children. How do I know this? Well, when we finished up in Tajura in March of 2020, we had registered 1,750 children in Tripoli alone. Now, I understand some of those children may have been crossovers. But when we left Benghazi in early February of 2020, we knew that Dr. Guba had a list of over 350 children that needed surgery. Dr. Rasmia had a list of over 200 children. Dr. Miriam had a list of over 150 children. So, you know, there's a very significant waiting list, and you've got 500 children born annually that are going to be added to that waiting list. Obviously, some of the children on that waiting list are dying, And so that's going to make the number probably basically stay the same. But nonetheless, healthcare in Libya needs to understand that congenital heart disease is a major problem in the country. Second, Libya needs to realize that training a competent pediatric cardiac team requires time and committed human resources. And I just don't know how to explain it any better than the fact that there is nowhere in the world that you become a pediatric heart surgeon with 1 year's worth of training. It just doesn't happen. You may be able to close an ASD or maybe close a VSD or do a bidirectional Glenn. But once you get into complex pediatric cardiac surgery, it takes a significant amount of time to train an individual to be able to perform that surgery safely and successfully. And it's not just the surgeon, although, quite frankly, the surgeons are the ones that take the longest to train because of the vast number of combinations of defects that make up congenital heart disease. So in order to be able to operate on neonates, that's a complete new area of expertise for most of the people that we're training. I mean, Hassan is the only one that I'm aware of, aside from our team, that has ever performed neonatal cardiac surgery in Libya. And Hassan didn't really train anybody to follow him. And so really, when we're not there, there's only one person in the country that can do neonatal cardiac surgery. So the third thing is Libya really needs to think about what do they want to solve this problem? Because if they do want to solve this problem, the country really needs to provide uninterrupted funding for a 2 to 3 year time period, which has the same human resources during this time period for us to train. And then I think, the next to the last thing, the fourth thing is to realize that neonatal surgery requires 3 to 5 years for a team to master. I'm not saying you won't be able to provide the surgery after 2 to 3 years of training by us, but what I am saying is don't expect Western European results right off the bat, because neonatal cardiac surgery and care is without a doubt the most difficult part of pediatric cardiac surgery, and that's recognized by anybody that actually does pediatric cardiac surgery. Lastly, this all needs to happen fairly soon. I've become a big advocate for the children of your country with heart disease because they need an advocate, and children are dying literally every day. I'm not going to identify the pediatric cardiologist that I got a note from just 2 days ago, but she was consoling a mother of a newborn who had died several days after birth because he had actually a surgically correctable problem, and yet there was nobody that could do it. This is commonplace. This isn't just something that happens once a week. This is happening multiple days, every week, every month of the year. So I'd like to thank all of you for giving me the opportunity to stand on this soapbox and talk about this, but it's disheartening, quite frankly, and frustrating for those of us that are trying to help Libya provide cardiac care and education of teams to care for these children and to just have constant disruptions for a variety of reasons, and now have a new government that can't pass a budget, and Allah only knows when that's going to happen and when our team will be able to come back. So, Minister Al-Oakley, I'm going to turn this back over to you. I'll be happy to take any questions from whatever format you'd like to do that in.
Thank you, William. I think if we can exit sharing so that we can see all the participants in case I'm sure we'll have some questions to ask. I think the benefit of having William's charity to come to Libya is multiple. He's been very humble to say they have not trained people. But I am sure that the number of nurses, ICU nurses, the number of cardiologists, pediatric cardiologists, the number of surgeons, I know at least 2 or 3 surgeons have been very close to William every time he come either to Tobruk or to Benghazi or even Tripoli. So there are people who benefited. I'm sure there are people who learned a great deal from this. I think what we, of course, we have not really reached a stage where we have someone who's fully qualified, simply because we didn't have a qualification capabilities in Libya. The other important benefit is the family. I think family who, first of all, they often have to find funding. If the chance of them getting funding on the government to be treated abroad is very, very negligible. I know that for a fact. So they often have to sell whatever they have, house, land, or whatever, cars, or borrow from families to go abroad, and they pay anything up to $70,000 or more. And the inconvenience, the difficulties they have to face in a different country under the stress of dealing with a very sick child who unfortunately have a chance to die. Because I remember on the first trip that William did to Benghazi, I was fortunate enough to be able to do a number of nearly 12 cases with him on that trip. And I think Naima told me that just early in the year 2012, we sent about 7 kids to a neighboring country for congenital heart surgery. Unfortunately, we lost 6 of them. The 7th patient refused to have operation, and he came back and we operated on him. It was subaortic stenosis, a very simple operation. We operated on him in Benghazi and he survived. He was a youngish man, about 16-year-old from Darna. I remember him very well. So it's not just the training, it's not just the cost, it's not just the inconvenience of the family, it's the whole package really that we were aiming for. The cost is also significantly less. If you take all the cost of the tickets, if there's a number of staff who have to pay the salary for the 2-3 weeks of them being here, and the accommodation of the staff in the transit country like Tunisia, the overall cost somewhere around the $5,000 or at least has been around $5,000 or in that range in the last many years. Compare that to the 70 or so you have to pay overseas, regardless of the other inconvenience. I think we are open to discussion. Anyone would like to ask, please raise your hands. You have to go to the reaction icon on the top of your screen, I think. I have it on the top right-hand side of my screen. You just press reaction and raise your hand so that we will be able to give you a chance to ask and discuss the situation that we are in. Thank you. Taha, tfadal.
Hi, Rida. Thanks, Professor Novac. Thanks for this nice talk. And to be honest, it's a sad story, I must say. And I lived some of it. I just want to ask you, Rida, here. I've seen some of patients and relatives as well in Tripoli, for instance, who they cannot afford the operations, even if it's been served by Dr. Hassan, for instance. And I saw there's a program, I couldn't understand it, where they can try to get funds from the government to pay the private sector. And some of them did really manage to get surgery. So I just want to ask you about that funds. Where is it coming from? How reliable is that? Can we attack that type of fund to make a, like a fixed, reliable fund to run a program in Tajura or in the eastern part, for instance? Thanks.
That's a very good question. And we have actually been negotiating with the هيئة التأمين الطبي so that we will get some funding. But it's very difficult because the ministry have tried also. I remember the Minister of Health and the head of Benghazi Medical Center having a meeting with the head of the medical insurance organization in Tripoli about 6 weeks ago. But until now, we still have, and they promised, they're committed to pay, but unfortunately, until today, there's no funding. Really, I think such a life-saving operation, if you have a kid, he has 60 or 70 or 80 years ahead of him, who needs $4 or $5 or even $10,000 to have an operation. And on one hand, you ignore that, which is really something I have to make that clear. And I hope that the minister will be able to appreciate that. I'm not saying this in any way to criticize him, but it is really a responsibility that we have to make clear to the ministry. I cannot commit $25 million for a radiotherapy center in Sabrata and Benghazi, and say I don't have funding for $2 million or thereabout to save the lives of 500 kids. Radiotherapy often is always given to cancer patients, some of whom will probably die. If not, most of them will eventually die and probably die very soon. Radiotherapy, we know, often used more palliative than curative. So it's an issue benefit ratio. Yes, if you have 25 years, put 2 million for the kids and put the 23 million for radiotherapy. I have no problem with that. But you cannot ignore kids altogether and expect them to, I don't know, because pediatric cardiac, as you know, Taha, kids with congenital heart disease, some will need surgery immediately within a matter of days. Arterial switch cannot wait for more than a few days. Otherwise, the mortality will become very high. The chance of them surviving the surgery will be very little. What the governments, both in the East and the West, did since I left the ministry, they will have agreement with private company, for example, to pay for a team, for example, to operate, or whether Libyans operating in government hospitals or inviting William, as it happened, for 1.5 trip, or they pay, or at the promise to pay private hospitals, and unfortunately, they never pay them. So the private hospital may support you for a few cases, but eventually they realize cardiac surgery is very expensive. We know cardiac surgery in Tripoli can be as high as 150,000 Libyan dinar or even more. And you only need to do 5 or 10 of these cases to realize, like, well, oops, we are in the red here, and the ministry have not paid. And as you know, trying to get your money out of a ministry, I'm not attacking one ministry in particular, but I know for a fact it's extremely difficult to get money out after it's been spent. And that's why it's often wise for anyone on the private consortium, private side, to deal with at least what we call LC. You open a letter of credit for that hospital, and then every time operation is done, it gets approved by the ministry, and then the hospital will take its money out of the bank immediately without having to go through the vicious cycle of papers are lost, or so-and-so did not receive it, or someone denying he took the file for that company to have it paid. And let alone the delay in payment. As you know, you find a lot of hospitals in Tripoli today they really demand millions of Libyan dinar from the government. And we know our private hospitals in Libya are very small hospitals. They don't have that amount of budget, that amount of money to be able to survive. They need that money to pay for consumables, for people, and so on. Thank you. I hope that is clear to your. Yeah, okay. Any more questions?
Actually, I have a question for
William, go ahead.
Yeah, my question is the Parliament actually going to pass the budget after Eid is over? Is the Parliament actually going to pass the budget when Eid is over? What do you think?
Maybe I'll ask Idris to answer that. Dr. Idris.
No, there is a problem at the moment. I think the East are, well, today and yesterday there was many discussion, or there were many discussions about why we don't have the budget. Is it for the West only? Is it for the East? I think there is hiccups here. There is a problem, obviously. Hopefully it will be solved quickly. So no answer for the time being, William. Let me ask you a question, all of you. This is, what Rida has said now. That's raised the importance of health economy. There is something called opportunity cost in the health economy. Rida compared the radiotherapy for a cancer patient, which of course is a problem. And the cure of child born with congenital heart disease, which can be operable and he will live for 70, 80 years. That's where science come when we talk about opportunity cost. So the minister has no problem in deciding what direction he should, or in where he will put his money. It is very obvious. There's something called disease burden. If he collect all this information and ask a team to tell him what to do, if I have $1 million, where I can spend this, where, in which area, in which part. This is science. It has nothing to do with what I think or what I don't think. So if you think about child, yesterday I have one child with congenital heart disease, transposition of great vessels. Now, as Rida is saying, his father is selling his flat. His mother is selling all her gold. They have a piece of land they will sell, and they are going to Turkey. All right. So here you are, one little child who will ruin the life of the whole family, and we spend a lot of money in other areas. So it is very important. We should raise these questions. I think the last slide that William presented today is very important. I will publish it, because that's something we should be very proud to be part of it. If we raise the awareness of these problems and direct the society and the decision makers towards this problem. Thank you.
Can I take Dr. Milad, our senior pediatric cardiologist, a Libyan senior pediatric cardiologist working in Saudi Arabia, a good friend, and I know he's a very وطني بالدرجة الأولى. تفضل دكتور ميلاد.
السلام عليكم. Do you hear me? I would like to start with, maybe for those who don't know me, I mean, I am Dr. Milad al-Saghir, pediatric cardiologist in the field for 25 years. And Assalamu alaikum, Amir Tuwati, Rida al-Aukudi, وجماعة ثانيين. Anyway, I am a good friend of Amir, I mean, classmate since the university time. Anyway, actually, pediatric cardiology or pediatric cardiac intervention in Libya, we have to say it is in the zero level. Whatever we do, whatever we did before is still in the zero level. Thanks for Dr. Hassan Maghur, he struggled at the time actually, and he did few things which make the problem visible, which is very important thing. I mean, I started to seek help and to seek to do some charity or visiting the treatment group or something like that, 2006. We came as, I am trained in Sweden, so we came with 3 other Swedish doctors, one in cardiac surgeon and one intensivist anesthetist and one senior cardiologist. At that time, I was junior cardiologist. And we came to Tajura. We stayed 5 days. We discussed with the colleague there, including Dr. Dr. Lewa and Dr. Muhammad Sassi and other doctors. Hassan, he came to us one day also. Salam Huma was there. And what William's saying today, we said it 2006. And what Rida answered regarding the cancer therapy compared to cardiac therapy and the costs, they told us that time. They say to us, if you are doing one switch operation costing 20,000 euro, we can treat 6 or 5 or 8 kids with a leukemia, and they are curable also. And at that time, unfortunately, we were few. We couldn't convince the Ministry of Health. We lost the discussion. And then after that, we continued struggling. I tried myself to do visiting groups, but always, I mean, you need a team like William doing now. He need an anesthetist, he need a cardiologist, you need a cardiac surgeon, you need a perfusionist, you need. That's one issue. So the staff we can manage because we have very good communication and connection worldwide. And many people, they are standing to help. But our problem here in Libya, you don't have the infrastructure. The major one, for example, if we're coming to do an intervention, you don't find the X-ray machine working. If you find the cath lab working in the X-ray machine, you don't find the table working. You don't find the supporting staff. Somebody locked the door and left somebody. And sometimes very few things. I mean, a wire, you can find it, so you cannot complete the intervention. So the complete setup needs to be thinking about. Then when I moved to Saudi, I find my colleague from Saudi Arabia, actually, they are in very good job there regarding charity visiting. And Rida, he know about a few of them. I mean, they are going 1 week, for example, to Sudan, complete setup, complete group with all stuff. They are doing 80 cases in 1 week. Believe me, I went with them. We did 47 cath intervention and 40 or 42 cardiac surgery. Some of them neonatal. But we are working from 7 morning until 9 evening. Everything supported to us. Food, rest, if you want to shower, if you want. That's how it should work. If we are going to depend on charity mission. And for the charity mission, of course, it is important to start with, because we cannot start stabilize it national with our own team within Libya. Unfortunately, because we don't have the staff, we don't have the experience. So we need to import the experience slowly through the charity mission, and then our team will learn. Then when we come to what sort of cases, pediatric cardiac surgery or pediatric cardiology cases they are very heterogeneous. So you need to classify them. The Swedish guys, since 70s and beginning of 80s, they classify them to organize their work when they started there. There's cases, what Dr. Idris said, curable. So you just operate them once, and they are 6 days in the ICU or in the hospital, and then discharged completely. There's some cases you treat them, they get survived. You need to follow them long life, and I mean they struggle, but they're doing well. And there's few cases which are very complex. You have to palliate them, and they are burden on the healthcare. They are staying chronic patient, and there's the mortality, and there's the so we cannot start with the complex cases. The neonatal surgery with Dr. William talking about, I think it is no time to start with it now. Only transposition arterial switch. That's it. Because this is, you can cure them. The others, you palliate them. If you want to start with them, you need to be precise that you have the program which will continue for minimum 2 years, because the palliation usually it needs 2 years to complete all the setup of the operations. But we can start with, we have many of ASDs, we have many of VSDs, we have many of fellows. This is the majority. And this, we can do them easily through the charity mission. Unfortunately, because of political issue, the Saudi groups, they cannot come to Libya from their own government, actually, because of the safety issue on that. But we can do things with our other Arab colleagues from Egypt, from Syria, we can collect each other. I know many people. Lastly, I want to say, who said some people who took a baby to Turkey. It's very important to know where to go when I advise because it is عفوا معلش سامحوني نقولها بالعربي سوري ويليام I will talk in Arabic. هذه زي انت ترفع سيارتك للورشه، ضروري تعرف مين الميكانيكي اللي يصلحها لك، لان مش كل واحد يعرف يعمل كل شيء. وبيني وبينك sorry, the Turkish cardiac surgery, they are not good. They have very much high mortality compared to the international level. Also the other countries. So if one need advice, we can send them to certain centers who do this specific operation in a good hands. And I always, my email, my WhatsApp, my messenger open. Yesterday I was in Zliten. They have cases. And they have cath lab. They don't have the stuff. And I just arrived to home for 1 hour ago.
Let me step in for just a second and add to your Turkish woes.
Yes, come in.
Okay? We have, over the years, whether it's been Tripoli, Benghazi, or Tobruk, we've had parents come back to us to say that someone in the ministry sent them to Turkey for evaluation and surgery, and the Turks do the evaluation, and that's the end of it. And Libya gets hit with a bill for that. I've seen some of those invoices, and they're not insignificant just for their diagnostics. Moreover, we've done a number of reoperations on children that have gone to Turkey for surgery. There's no registry. Nobody knows what the real result is of the children that go to Libya, from Libya that go to Turkey for surgery. So it is problematic, I think, and I think it's indicative of the fact that there's really no focus by the ministry on children with heart disease.
I also comment on that.
I agree with you, William.
Dr. Milad, sorry, just to comment. Yeah, I was in Tripoli in 2013. When they opened this, like fly out and operate difficult cases. So Dr. Hassan was one of the guys who had to like send the complex cases. And those days, the phone tunnel, so he didn't have a lot of experience, so he wanted to go. I had to like travel myself also to look at one of those hospitals and just confirm how good they are. Because what happens is the Libyan, as soon as they get there, the family, they get caught by these, I would call the health business people or whatever they are, and they send them to the cheap surgeons, cheaper, and most of them come with the disaster results, and some of them lost their kids. So I think there was one guy that we had to get in touch with, Dr. Tayyar, I think in Acıbadem in Istanbul, but I think they couldn't do it for long because it's quite expensive. And that's why the business won't work for this government or the ambassadors there, to be honest. And that's, I think it's an issue with, it's basically business.
Milad, كمل تفضل.
It is not right to say generalize all Turkish healthcare services bad. We cannot say that, of course. But in our experience, as you said, they get caught with some people. And for 2 months ago, fibroid uterus, one asked me, they get an invoice with 20,000 USD for a fibroid uterus. I told him, this is ridiculous. It cannot be in Turkey. 27,000 USD. And I told him this can be done, in my experience, I think it would be done not more than 5,000. And after many communication, we helped him to communicate with somebody in Tripoli, and he did it with 3,000 plus USD here in Libya when the woman survived it. We have an experience, me and Dr. Tariq Momin, I really know him. In 2013, we came to Benghazi, we did charity visit for 10 days. And we found a girl who was 23 years old, severe coarctation, almost interrupted aortic arch. And she was in Turkey, and there they want to do her surgery. But they told them that their mortality rate is very high. Then her brother refused to sign the consent. And we did it with a cath intervention with a covered stent. I mean, in Benghazi Cardiac Center, me and Tariq, without any other things. Yeah. I mean, you may find some people in Turkey or in Egypt or in Syria or somewhere else are good, but you need to know them, not just go private person in the airport and go and do things. That's what I want to say. And in summary, we need to categorize what we want to do to succeed. Otherwise, it will be we just talk. And he was with me in many meetings. We are just talking. We don't achieve anything. Shortcut. You need a charity mission. They know what to do. You need a financing, of course, but it has to be continuous. So the local people get trained. We start with nurses. We start with ICU. We start with a perfusionist, and some cardiologists and some cardiac surgeon may do simple things. Thank you very much.
Dr. Milad, thank you very much indeed. If I may just add to your comment, I think charity in Saudi language is different to charity elsewhere, because I know charity in Saudi is an open check. I know how much it costs to have a team coming out of Prince Sultan Cardiac Center going to Yemen for a month. It's a lot of money. Believe me, it's far more than we're even thinking. It could be as much as we're asking for a year. نعم.
I agree with you. لا بس بقول لك حاجة معلش لأننا involved in this. مشان موريتانيا والسودان واليمن charity mission not supported by the government, supported by a charity donation. and we calculate how
Still
much
a
it
lot
costs
of
us for
money.
cardiac surgery.
How much was it?
No.
How much?
I will tell you.
How much?
No, the money is a lot, but we operate. I mean, almost 100 cases per 1 week. You remember when we calculated per patient, it come out somewhere between 2,000 to 3,000 USD.
No, but if you include angio as one of the numbers, it's not. I think if you talk about the open heart surgery, the cost will be much more than that. Don't you agree? And your charity.
Yeah, of course we include, but we treat it.
Yes.
Okay,
Yeah,
of course. But I agree. The cardiac surgery it will be more expensive, but it will not reach what we paid. Okay.
Yeah. Milad كملت. You're gone quite. The other point I wanted
yes,
to
I finished it. Yes.
Thank you. I just also would like to add to your comment that when you land in a hospital and you can do a lot of cases, that the infrastructure also important as well. Yeah, number of ICU beds. If you look at the number of operations done by William and Tobruk is relatively less per visit as it is in Benghazi, because Benghazi Medical Center have no problem with ICU bed, plenty of ICU beds, plenty of OR. So if you go to a hospital with 1 OR and 3 ICU beds, there's no way you can do many cases, the cases that you would be able to do. And if you get there with a limited number of staff, like 15, it's not the same like you get there with 30 or 40 people around you. And also the environment.
I agree with you, Rida. I agree. I mean,
no. You also,
I agree with you totally. I said this example, but I don't mean we have to do it. It is very tough.
No, it's important. I think I agree with you. I think we should push as hard as possible, but we need to keep things in perspective. The last thing is the outcome. And I think I'm surprised William did not put a slide on his results. Maybe I'll go back to William to ask him what was the outcome of surgery in Libya. William, over to you.
I think Aimer is raising his hand as well.
Hang on. So we've actually looked at our Libya numbers recently, and you know, there's a very interesting trend, and that is that our mortality was actually highest in Tobruk, and it was very close to 8% overall, all comers. Our mortality rate in Tripoli was sort of in between Benghazi and Tobruk. The mortality rate in Tripoli was around 4.7%. And don't hold my feet to the fire on these exact numbers. I can pull the data back up and send it to all of you later. But our mortality in Benghazi has been the lowest. And this year, out of 117 cases, we've lost 2 children only. And both were neonatal cases. Well, let me change the way I've said that. Both were under 2 months of age. One child was a Al Kappa with a very depressed ejection fraction that we lost, and the other was a pulmonary atresia, intact ventricular septum with RV-dependent coronary flow that we shunted, and the child did reasonably well early, but then we got into a real problem with shunt overcirculation on this child. So we took him back and banded his shunt a little bit, and that markedly improved things. Unfortunately, the child had a medicine miscalculation, for lack of a better way to put it. And he achieved an ACT level for the surgeons in the group of 900 post-operatively. Yeah, Taha. And literally bled to death the second night after the shunt banding. So that's it. That's the sum and substance. I mean, we've done some Rossellis over there on this last trip. We've done a number of AV canals, complete repairs. Obviously the TETs and the VSDs, they all do fine, but those are the only 2 children that we lost. We have 3 other neonates that did well. There was a TGA, intact ventricular septum, presented to us at around 40 days of age. That's not usually an age that we shy away from doing a primary arterial switch on, but the child's echo was disturbing. The child already had a banana-shaped LV, and the posterior wall, LV wall thickness was inadequate, quite frankly. It was only 3, maybe 3.5 at the best millimeters. So that child got a septectomy, abandoned a shunt, hoping that we'll be back at some point and can take that all down and do his arterial switch. The other child, I think both the other children were just neonatal shunts.
Thank you.
Dr.
Dr. Amr, I'm sorry you raised your hand. We will get stuck with the technical details because of your friend. So, Dr. Amr, floor is yours.
Okay, thank you. Thank you, Professor William and our colleagues for this nice session. I think the subject of the session was about the pediatric cardiac surgery. But in fact, it's highlighted the major issue of the healthcare system as well. I mean, the people talk about the bureaucracy, the international cooperation, the charity, even the trust between the parents and the Libyan system. Also, it's raised an ethical issue, ethical dilemma when you talk about the scarcity of resources. When you have a limited resources, where you put it? Whether it is go to the pediatric cancer treatment or pediatric cardiac surgery, lots of issue, and I think it will get branched more and more. So my perspective here is to concentrate on one point, let's say about the charity or international cooperation, and try to find the way to do that, because it is, you know, yes, it is small children, but it is a big talk. Thank you. Over to you, Rita.
Thank you. Thank you. Okay, next is Nuria. Sada Nuria Al-Amami. She's the head nurse in the heart center in Hawari. Please unmute yourself and speak.
Unmute. Assalamu alaikum wa rahmatullahi wa barakatuh. دكتور رضا الصوت واضح عنكم؟
واضح واضح.
معلش دكتور ممكن أنا نحكي شوية بالعربي وبعدين نخش في الكونفرزيشن، لأن أنا يهمني بنوصل مسج بسيطة بعد إذنك يعني. طبعا أنا لا تفضل. أنا نورية العمامي. يب. أنا نورية العمامي سينيور نيرس في الكونجينيتال تيم مع دكتور سالم رحومة ودكتورة رسمية الفيتوري ودكتورة مريم المعداني ودكتورة نعيمة قوبعة في الانترفنشن في الانترفنشن يعني خصوصا. احنا عندنا بس جيت في جزئية متأخر، لكن معليش حابة نصحح معلومة إن بالنسبة للقسطرة التشخيصية والعلاجية في بنغازي في مركز القلب خصوصا تشتغل بشكل كويس بشكل كبير. نحاول نغطوا الحالات من كافة أنحاء ليبيا. في سبورت يعني من الوزارة حقيقة، يعني نقولوا يعني ساتسفاي من الأدوات ومن المواد. في شورتج حسب السبلاي لأن في مشاكل التوريد على معظم البلاد مع السيتويشن، ولكن رغم ذلك خلال كورونا احنا اشتغلنا فوق 100 حالة انترفنشن ما بين ASD ما بين BTA ما بين BS، يعني عملنا انترفنشن بالون دايليتيشن للأورتيك ستينوسيس، عملنا راشكنز يعني سبتسمال كيسز. فعندنا تيم نيرسز كواليفايد نيرس نديروا في نحاولوا ان احنا نزيدوا العدد، لكن الحمد لله نعتبره في الانترفنشن ماشيين كويس. نتمنى جدا كاردياك سيرجري مبسوطة على الآخر من ورش عمل الدكتور ويليام نوفاك والجمعية اللي في مركز بنغازي الطبي واللي استمرت في طبرق بعد ما صار الأحداث، وما رفعوش يعني ايديهم وما يعني ما قالوش احنا وقفنا، بالعكس استمروا، عطوا شغل كبير، استفادوا منا كل من عمل يعني جوينج. انا عن نفسي استفدت في الكاردياك انستيزيا واشتغلت معاهم حوالي 40 حاله في وحده من ورش عمل في 2015 از كاردياك انستيزيا. فبصدق يعني نتمنى انه ما يوقفنش الكاردياك سيرجري بالنسبه للبيدياتريك، لان الاعداد اللي بعد الحالات هذينا تزادت وقاعده تزيد، نحاولوا نحلوا مشكلتها. مركز القلب فيه سيت اب كويس، اي نعم يبي نوع من سبورتيف للبيدياتريك، ولكن جست يعني هو مهم جدا جدا انه هو ما ينحط في الاعتبار لو تبي تنعمل اي ورك شوب جديده. ايضا بي ام سي حرام يلتغى، لان تم تحوير العنايه هذه بشكل كبير، وهي يعني حرام تلتغى. يعني ليش ما يكون كونجينيتال في مكان وادلت كاردياك سيرجري في مكان؟ يفترض بالشكل هذا، لانه هو مستشفى عام في كل التخصصات. انا رايكم، لكن انا بس حبيت نوضح نقطه القسطره التشخيصيه والعلاجيه اطفال. راهي نحن عندنا كواليفايد تيم ولله الحمد. شكرا.
Just summarize for William's benefit. This Nuria Al-Amami, I'm sure you know her. She's a senior nurse with really very wide experience in intensive care, invasive cardiology, percutaneous interventions, and so on. And she said that they did 100 cases of percutaneous intervention for congenitals in Hawaii. And she believed that your service have been very beneficial to many people, including herself. And she believed that this should continue, it should not stop. And we hope that we'll be able to find a way to keep that service running. Thank you. Anyone else? Yeah.
Thank you very much.
Please go ahead. Yes, sir. Thank you. Shukran, ya Nuriya. Anyone else would like to speak? Please raise your hand.
I'd like to ask Idris a question because I missed before I actually started speaking. Idris, you had mentioned something about creating some sort of a program plan and I don't know, forming some sort of a group and then doing what? Going to the ministry with this, or what exactly? Could you go back over that a little bit, please?
Yeah, sure. I think what we normally would do at the end of this, we'll have a summary of the recommendations made through this session after discussion. And Dr. Amil has been very kind actually to be able to make the summary. And he also committed to hand this over to the minister in a very direct way. And we hope we'll do the same. I think we'll have the summary done, and then we'll forward to the minister's direct WhatsApp number, so we know for sure that the information have landed in the right place. We've been communicating with some organization in Tripoli in order to be able to seek funding, but really that is again not very easy, because the ministry sometimes see this as we are bypassing it. They're not happy about we as professionals doing the job of the Ministry of Health. But we really do hope that the ministry help, or at least support our endeavors, our attempts to make this service available in whatever way, wherever we can do it, whether in Tripoli, Benghazi, or the south, maybe eventually, we hope. Who else is requested to talk? Taha, did you raise your hand?
No, not really, no.
Okay. Dr. Mariam, please unmute yourself.
Assalamu alaikum. Assalamu alaikum. First, I thank everybody prepared for this meeting. I will talk about pediatric surgery for cardiac surgery, because we suffering in the time where this coming of this drip not there, when there is no pediatric cardiac surgery available. In the last few days, we do Rushkin for case of TGA. He is now 16, 17 days. I think we will not have any chance to do this surgery. We know all this TGA. He has a limited time to do the intervention. The pediatric surgery, cardiac pediatric surgery, it is not a surgeon only. He need pediatric cardiac intensivist. He need perfusionist. He need a qualified nurse. We sorry in this years and years. I know this team. He came interrupted. He is not continuous, but still we have no this specialized for caring this child with congenital heart disease. We have no special pediatric cardiac intensivist to take care after pediatric cardiac surgery. We have no local perfusionist, no local intensivist, no local. No, I know some nurses good now, but his limited number. But no pediatric intensivist. No pediatric intensivist can take the caring of this child after this. Even if there is pediatric cardiac surgery available, without this specialty, we could not do any pediatric cardiac surgery. That is all.
Thank you, Dr. Mariam. I met you, I think, in the last trip of William to Benghazi Medical Center a few weeks ago. And I would like to ask you, you were one of very few local You came from Hawaii all the way to Benghazi Medical Center. ICU nurses interested to intensivist or intensivist in general. Dr. Mariam, did you hear my question? Maybe the internet went weak a little. I'm asking you, where is everyone else? Why no one else signed up? Yeah, go ahead, please.
I couldn't hearing your question.
Sorry, yeah, I said I met you in Benghazi Medical Center, and we thank you for your commitment to support the team. My question is why there is no other people, no nurses, no ICU nurses, no intensivists, no anesthetists. There was only one surgeon, I think, from Tobruk. Please go ahead, yeah.
Yes, according to the nurse, there is some maybe 2 nurses coming from Benghazi Cardiac Center, another one from 7 October Hospital, another 2 or 3 nurses from Benghazi Medical Center. These around 6 nurse is good nurse, but still need trainees. There is no any pediatrician doctor. He came and attend this in one month. I didn't see any pediatrician doctor come and attend. Even the cardiologist, he's limited number. He's the same faces in every visit. No other cardiologist came and attend.
Well, Miriam's correct on this. And let me say that this has been a frustration of ours since we left Benghazi in 2014. You know, there've been multiple directors at Benghazi Medical Center since that time. And I think the lack of a continuous program in pediatric heart surgery has resulted in very few individuals on the nursing staff, ICU nursing staff, who had any skills in caring for these children. So this recent trip, it was like subcontracting out to other hospitals to get an adequate nursing staff to participate with our nurses. And as I mentioned, and Miriam mentioned, at no time was there any participation from any pediatrician in this program. You know, I have brought this up since the very start, back in 2012, that since there are not, a lot of intensivists for children in Libya, that you need to take senior level pediatric residents and they need to be involved in the program on a regular basis so that they can be taught how to take care of children with congenital heart disease, whether it's after surgery or after intervention in the cath lab. There has not been anyone, literally. Now, the one difference is in Tripoli. And Dr. Hanifa had brought several of her pediatric intensive care colleagues, as well as nursing staff, over from Tripoli Children's Hospital to be involved in the program. But literally that program only ran for 6 months before it was disrupted. Human resources are a major problem. And the issue is it's hard for a hospital to commit human resources to a program that is interrupted as consistently as our program has been interrupted. You cannot train people and expect to retain people when you show up, I don't know, 3 times a year, maybe, and maybe skip 3 or 4 years before you're back at that particular institution. This is part of the problem, but this problem could be solved if the funding was consistent, if the training team was there on a consistent basis, then you would be able to do this. But getting the pediatric healthcare professionals in the country to back a program, whether it's children coming over from, whether it's nursing staff and pediatric residents coming over from Benghazi Children's Hospital, whether it's the same group coming over from the Tripoli Children's Hospital. I mean, if you don't have the staff to train, you're not going to have a program. That's basically the sum and substance of the problem. And you're not going to get a staff to train if the program is not consistently there.
Thank you. Thank you. Amal Abu Saif, unmute yourself, please.
السلام عليكم. تسمع فيه دكتورة أمل أبو سيف بنغازي ميديكال سنتر. Hello, Dr. Novak, Dr. Reda, Dr. Idris, Dr. Mariam, Dr. Milad, all of you. Thanks for this meeting. And I'd like to thank Dr. Novak and you, Dr. Reda, to allow such workshops, serial workshops, starting a few years back till this year. And we have got a lot of benefit. First of thing, and briefly, for succeed or such workshops, we need a continuous program for at least continuous 3 years, for benefit of the patients and benefit for trainees themselves. As you mentioned earlier, the other thing, I agree with Dr. Mariam. Did you imagine that last workshop, Dr. Mariam alone attended daily for 1 month regularly, maybe about 24 hours alone in ICU. For me and Dr. Najah, only 2 persons attended daily, even in holiday, at post-operative, for post-operative and pre-operative care. It's too much. As Dr. Mariam said, we need serial meeting. If there is another workshops, more organized, and we should do a plan for trainees. And also we should, the other doctors in other hospitals, either in Benghazi, in Tobruk, in Derna, all of them should participate in such workshops, because all of them send patients. So at least they should attend and know how to take care about the children post-operative. They can improve their skills. All of these things, if there is another workshops, so we're supposed to do serial meetings with the Benghazi Medical Center, BCC, cardiac center, and all of us should participate in such workshops. Thank you, Dr. Rida, and I hope we'll have a continuous program because it's not benefit for the patient. They will be accumulate number and accumulate problem, will not solve a problem. Each time we have a long list. Every time we'll hope that the number will be decreased and we solve previous cases, but there is accumulation of cases and every time there is delay. I hope for very, very succeeding future and surgery and plan. Thank you, Dr. Rida, for your effort. Thank you, Dr. Novac.
Thank you, Dr. Amal, for a very clear message. I think we hope that will all be summarized and reach the minister hopefully soon. Dr. Milad.
معلش, I want to say something.
Please
Libyan doctors, thank you. Libyan doctors and Libyan situations, it is not unique. I mean, what by the way, thank you, Dr. Mariam and Dr. Amal, what you are doing and your solidarity. But the problem we face everywhere in the world when we go for mission or any workshop, you find the local people, you think they are interested, but it is not they are not interested. We come there. So when we come, they will not be able to change all their programs and their social life or their private activity or whatever it is for your sake. And they may stay with you 1 or 2 or 3 days as solidarity, as but at the end they have to do for their own. You want the local people to come, you need to get incentives or they get from their work, because not ask to Benghazi support you to run their own clinic somewhere else or their program. I agree with you. It is, we think it is strange people coming from abroad to help on the local people patient, but this is the fact. I haven't, it happened the same thing. He know him. He to have the same problem. People not interested. You need to remember. You need to them. To your full. 1 month. It is not realistic. You have
my internet or yours? The sound is very bad. If you can hear me.
Do it for a short. That's what I want to comment. I have to say, the is coming. Amr said, "You don't hear me."
Thank you.
Hello.
Thank you, Milad. I'm sorry, the line is very bad. Is it mine or yours?
I think it's his.
I don't know. What about yours?
No, it's Milad. I couldn't understand a word he said.
Yes, your line is terrible, I think. I think you need a better internet in Hoon. Not just pediatric cardiac surgery.
Okay.
Okay.
Thank you.
I think, thank you. Any more comments? Anyone would like to please raise your hand? Otherwise, I will ask, the second speaker, unfortunately, we have run out of time, but you have also apologized. Maybe we will have to make another session for him, hopefully in the near future. But for now, I will ask Dr. Amr to summarize and conclude, please. Is Amr still there?
Yes, Yallah.
Yes, please go ahead.
Yes, here I am. I think William has summarized what we have to summarize in one of his slides. He pointed to the necessity and also the priorities of need. He have prioritized them first and second and third, as he put that in his slide. I think that will summarize most of the issues. However, apart from that, I think we have something also to put in our summary, including the concentration on the way we run such programs. Also, we have to emphasize on the lost and still continuous lose of money and lives, and what's so called the sending people, particularly children with pediatric surgery abroad, and spending millions of dollars or whatever, and the result is very bad, as Dr. Rida mentioned. Also, we have to emphasize that cannot be good training and train people to become competent without having a good service. So that's is interconnected together. Also, the program provided by Dr. William for the last decade or so is quite important, and we need to support that and go in that direction, because we might not find somebody else do that in such situations. We all know what they are. So the cooperation is very important. The role of the ministry is quite important here. The minister himself and his administration should realize the importance of such opportunity and build on that. I think that's most of the things we have to do. Can add, Rida, or Dries, anybody. Thank you.
But I think I will hold you responsible in front of everyone that this message will get to the minister loud and clear. As always, I have to thank William, and as always, William have to have the last word. Go ahead, William, please. Please unmute yourself. William, can you hear us? William Novac. You need to unmute yourself. Is your electricity out, William? All right, I think there's no William. He probably has a problem with the internet as well. Okay, is your electricity back, Idris? Congratulations. You are on mute. Unmute yourself. You are on mute. Okay. So, okay, in that case, you better have the last word if William is not going to have it. It's yours. Thank you, Idris. Thank you very much.
Are you talking to me?
Yes.
No, he was talking to me, and I got a.
Here is William.
Yeah, I'm sorry. I got a computer hack in the middle of our.
There you are.
Yeah, I got a computer hack right in the middle of our talk.
Oh dear. Can we see your face here, William? Please turn
the. Time, okay, it's really going crazy on me, this thing.
All right.
There, I'm back. Okay.
That's
sorry.
Better.
Okay. There are multiple problems, and I think that we've outlined all the problems during this discussion today, at least for pediatric cardiac surgery. I think that it's imperative if we want to build a pediatric cardiac surgery program, additional pediatric cardiac surgery program in Libya. I think it's imperative that the pediatricians and the pediatric cardiologists actually get behind this program completely. And that's something that we have not really seen to date. Yes, the pediatric cardiologists in Benghazi, not all of them, but most of them attend the echo diagnostic workshop that we run on a pretty regular basis all the time. But we still have a human resource problem for anesthesia, for pediatric intensive care, both at the doctor and the nursing level. And until the pediatric community itself commits to solving this problem and pushes the Ministry of Health to fund a solution then we're going to have the same problem we've always had, and we're not going to end up being able to build a team, a local team. And that's really our model, is to build local teams. We have been successful all over the world in doing this, even in Iraq, for crying out loud, another country that's been in continuous conflict. So it is doable, but you have to get a buy-in by all stakeholders. And until you get the buy-in by all stakeholders to push the ministry to do something about this, then it's really just going to end up with the same result. So I personally would like to thank everybody that attended today. I'm looking forward to Rita's summary of this. And, I think that, Rita, your idea to send this to the minister's WhatsApp number is certainly one possibility. But, you and I both know that he's in Benghazi frequently meeting with other hospital directors. And it might not be a bad idea to put this in the hands of Dr. Fathia at Benghazi Medical Center and ask her to physically put this summary of suggestions and concerns into his hands, physically put it in his hands. WhatsApp is great, but only if you pay attention to it. So.
Absolutely right. Thank you. Thank you very much indeed. Thank you, everyone. I think with this note, we'll stop here, and I look forward to see you in future webinars. Thank you very much indeed.
Thanks, everybody. Bye-bye.
Thank you. Thank you. Thank you, Doctor.